third fontanelles has been 6.4% in unselected population of 1020 newborns. So this one is a rare fontanelle. Between the anterior fontanelle and the posterior fontanelle, there is a third fontanelle present in the neonates. So molding of the fetal skull, how it is molding during the birth delivery. So this topic is related to the labor. When the female goes to the normal vaginal delivery during this process of the molding starts. So what is molding? Molding is a means shape, approximation or overlapping of the skull bone. The bones of the neonatal skull overlap over the sutures. When neonatal skull makes a new shape for to help or ease for the vaginal delivery. So adaptation of the fetal head to the pelvis cavity during the birth called the reduce the head circumferences. During the birth, the pressure on the head caused by the tight birth canal may cause the mold. To mold means shape, change the shape, the head into the oblong rather than the round shape. As the picture shows, there is the birth canal, there is the molding of the head. And the second picture shows there is the molding of the head. So outcome of the molding resolve after the delivery or within the few hours. It takes a few hours. The fetal skull contain the brain, which may be subjected to the great pressure on the head passes through the birth canal. So during the term condition, 37 to 40 weeks of the pregnancy during the delivery, fetal skull is then pelvis. So there are different presentations and the obstetrical importance. The cephalic presentation during the delivery has the vertex, brow, and the face. As the picture shows, there is the vertex, brow, and the face presentations. So this picture shows is the vertex, brow, and the face presentation. So vertex is the area between the anterior fontanelle and the posterior fontanelle and between the two parietal bones. While the brow is from the anterior fontanelle coronal suture to the root of the nose are orbital ridges. And the face areas between the from the root of the nose are the supraorbital ridges to the mentum or the chin of the mandible. So this presentation is a vertex presentation in which their head is fully flexed and it is quadrangular area bounded anteriorly by the bregma and the coronal sutures as already discussed, and posteriorly by the lambda and the lambdoid sutures, and laterally by the lines passing through the parietal eminence. Brow are sincipital presentations. Head is partially extended. It is an area bounded by one anterior fontanelle or bregma, coronal sutures, other side by the root of the nose and supraorbital ridges of the either sides. And the face presentation, the head is completely extended. It is area bounded one side by the root of the nose and supraorbital ridges, and other side by the junction of the floor of the mouth with neck, mentum, or the chin. As the picture shows, there is arrow, there is the mentum of the chin, and the root by the supraorbital ridges are the root of the nose. So in the last one is a diameter of the skull and its relations. They are classified into anterior and the posterior diameter are called the longitudinal diameters, and other are the transverse diameters. So what are the importance of the diameters? When the fetus come in the delivery time in the uterus lower pole or pelvis, then the diameters are measured. So which diameter is there? So what attitude according to the diameter? Attitude means relation of the fetal part to the one another, like the extensor presentation, flexed or partially complete, or the completely flexed or deflexed. So they are classified, anterior-posterior diameters are classified into six categories: sub-occipito-bregmatic diameter, occipito-frontal diameter, sub-occipito-frontal diameter, submento-bregmatic diameter, mento-vertex diameter, and submento-vertex diameter. I will describe everyone in the next slides. So what is the sub-occipito-bregmatic diameter? So this diameter starts from the occipital region, in which the head is flexed and extends from the occipital protuberance till the bregma, and the size is 9.5 centimeter. As the picture shows, there is the occipital protuberance to the bregma of the skull. Occipitofrontal diameter, in which head is deflexed, extends from the occipital protuberance till the glabella. As the picture shows, there is the from the glabella to the occipital protuberance. It is size is 11.5 centimeter. Suboccipitofrontal diameter, the point below the occipital protuberance till the midpoint of the frontal suture. The size is 10 centimeter. As the picture shows, there is the front mid of the frontal suture and there is the occipital protuberance. Submentobregmatic diameter is the in which head is fully extended. Start from the mentum of the chin, and the point extend the chin to the bregma. Bregma is the point where the two sutures, coronal sutures, anterior suture, and the sagittal sutures meet, and size is 9.5. Mentovertex diameter. It is highest diameter of the anteroposterior diameter, in which there is a head is completely extended. The point extends mentum of chin till the point of the vertex. As the picture shows, there is a from the mentum of chin to the vertex point. This one is highest diameter, size from 13.5 to 14 centimeters. And the submento vertex diameter. In submento vertex diameter, the point extends from the chin joint to the neck till the vertex point. The size of the submento vertex diameter is 11.5 centimeter. And last one is the transverse diameter. In the transverse diameter, there are 4 types of the diameters. There are the biparietal diameter, bitemporal diameter, supersubparietal diameter, and bimastoid diameter. And one by one, by the biparietal diameter, distance between the two parietal eminas. As the picture shows, these are the parietal eminas. Between the two, there is the biparietal diameter. The size is the biparietal diameter is 9.5 centimeter. And the bitemporal diameter, it extends from the farthest point of the coronal suture at the temporals. Its size is 8 to 8.5. This is the bitemporal diameter. Its size is 8 to 8.2 centimeters. And supersubparietal diameter. As the picture shows, the supersubparietal diameters, it extends from above the parietal eminence of the one side till the below point of the next parietal eminence. As this picture shows, the above from the one parietal eminence and second from the below the subparietal eminence of the next of the parietal bone. And the size is 8.5 centimeter. And in the last, there is the bimastoid diameter. The distance between the mastoid process of the temporal bones size is 7.5 centimeter. It is smallest diameter of the transverse diameter. As the picture shows, the red line shows there is a bimastoid diameter. So this is all about the anatomy of the neonatal skull.
Thank you, Dr. Suhail. Dr. Shad Ayub, are you with us? Okay. Thank you very much, Dr. Suhail. We'll see if there is
Thank you, sir.
any discussions or any questions regarding this presentation. Very
Dr.
nice
Ahmed, I'm
slides.
here. Yes, I have.
Okay. Do you have, Doctor, any comments or questions or?
Regarding the
I think, it was a nice presentation. Very
Thank you, sir.
detailed overview of the skull and neonatal skull with all sutures. I think if the audience have any question, they are welcome to ask questions.
I have a question for you, Dr. Suhail.
Yes,
Regarding the diameters you talk, usually the most common diameter we usually measure is the occipitofrontal diameter.
Yes,
Can you please
Thank you.
explain how for residents or for medical students how to measure the diameter for the newborn?
during the I think birth delivery, during they are bearing the
وعليكم السلام. Security good. The Khayyam security good.
Yeah, I'm guessing.
Dr. Said,
Yes, sir.
if you please can you explain for residents or for medical students
Yes,
how
sir.
the steps to measure the diameter of the newborn skull?
During the delivery of the
After delivery, yes.
yes, after delivery, yes, sir.
And
Then
usually,
we
what is
may
the best
adjust.
timing? What is the best
Yes, sir.
timing for measuring? Because directly after delivery, there will still be effect of molding, so size will be changed. Yes, as you
Actually,
explained in
after
your
delivery,
presentation.
there is a modeling of the skull. After few hours, then
Yes.
When the modeling of the skull resolves, then we measure the diameters of the skulls.
Okay.
Yeah.
Ahmed, I think we have already short of time in the first presentation due to difficulty in screen
Okay.
sharing. So would it be better to start second presentation?
Yes, it's all for you, Doctor.
Yeah. So let me have the privilege to introduce Dr. Sajad Dawar. He is assistant professor at Khyber Teaching Hospital and Khyber Medical College, Peshawar, and he would be talking today on the skull sutures and brief on craniosynostosis. So, Dr. Sajad, are you here?
Yes, sir, I'm here. Can you see it, sir?
Over to you. Please start your screen sharing.
Also. So, can you see it, sir?
Yeah, we can see. So,
Please make it in full screen mode, Professor, Doctor.
Yes.
You cannot see your screen.
Can you see it now, sir?
No, you exit as screen sharing. Yes, now it's good. That's perfect.
yes, now we can
Okay.
see the full screen. Yeah.
Okay, sir. As sir introduced me, it's very kind of him that he introduced me very well. I'm Dr. Sajad Ladawar, working as assistant professor at Khyber Medical College and mostly deal with the undergraduate students. So the presentation is basically keeping in mind the undergraduate students. And also, I would like to give credit to my fourth year MBBS student, Dr. Gul Mahanur, who helped me in making this presentation so that the student can share their perspective as well. So I hope the student will enjoy. So before starting my presentation, I would like to focus on these two pictures for the students that they should focus on these two pictures where this one, especially over here, if you can see the cursor and the other picture. So after the presentation, we will discuss these two pictures that what it means and how it look like. So the learning objectives for today is the anatomy was basically very well explained by the previous presenter, sir, and Suhail. And so my job is a bit, it's very easy now. So I will do not focus more on this anatomy of the skull. So I will more be focused about the overview of the craniosynostosis and the different types of craniosynostosis where we can understand the concept of craniosynostosis and different types and outline the associated factors and complication. And the third will be about differentiating craniosynostosis from other skull deformities. That is the positional plagiocephaly, that is more specifically. And in the last, we will be focusing on key takeaway messages and case presentation. So if there's a bit of animations in the presentation so that the students can focus and learn more. So here you can see, although it was previously explained very well, but just a sort of animation that these are the different types of bone of the skull that they make sutures, which is segregated. You can see over here. So the sutures on the skull interior, the different facial bones, frontonasal, frontozygomatic, zygomatic-maxillary. So it all aids in some part of the craniosynostosis in the syndromic part, but not in the single suture. So just an overview of the sutures of the facial bone. The anterior maxillary, zygomatic, and all these sutures. Then the interior, the most important one is the metopic, that is the frontal. The two frontal bones are fused together. They usually disappear between 2 to 7, from 2 months to up to 7 years. So the superior aspect of the skull, as mentioned, they have the coronal sutures when the frontal bones are connected with the parietal bones. Then, and the interior part is called as the bregma. The posterior aspect of the skull, we see the parietal bones that is connected with, through the sagittal, and posteriorly with the parietal and occipital are through lambdoid. And lambda is the giant pine that you can see in the red star over here. So the importance of skull suture is, as previously mentioned, that it allows temporary deformity and flexibility of skull through birth canal during birth. The overriding of the sutures help in tackling the natural process. And the other important that it is, it's a sort of a fibrous connection that inhibit the bone from separation for the protection of underlying soft tissue. So there, it is a suture, but it allow the slight movement, but keep the bone pieces intact as well. So there are two functions of it, that it does not prevent. It does prevent separation of the bone pieces, and it does not hold the growth of the brain. It permits incremental growth of the skull in babies as their brain grow until they ossify and fuse later in life. So it influences the development of facial and cranial proportion, and it's important because it is such of dynamic sutures. A dynamic suture means that over the time they add bone to the skull, and it increases in size while the keeping the bone piece in hand. So as the brain grows, they give the space that is needed for the normal development and give the shape to the skull and to the face. So as previously mentioned, the different sutures and the timeline of the closure that is important. The metopic closure mostly at 2 months, the sagittal suture close at 22 months, the coronal 24 months, and lambdoid 26. So all of them are, you can just add 2, and then you can easily remember that 22, 24, and 26. The squamosal is not important, that so you just, if you do not remember it, it's okay. So again, another animation that how craniosynostosis occurs. So this is numbskull. Then if the sagittal is closed, so it will look like this. So the brain is increasing in size when there is so then if it cannot increase in size in one proportion, then to compensate for the growth, the skull increase in direction, interior to posterior direction. So that's why it's become elongated. So ossification and obliteration of one or more cranial sutures prematurely before the functional need for adoption is complete. So that's called the craniosynostosis, because the functional need are not met because the brain develop over the time. So if it's not met and it's closes prematurely, then it will become the craniosynostosis. The prevalence is 1 out of 2,000 to 1 out of 25,000 live birth, and most common developmental craniofacial deformity after cleft lip and palate. It can be syndromic, non-syndromic, phenotypic, and non-phenotypic. Sutures involved determine the resultant head shape abnormality, and it can be best described by Virchow law, which tells us that dictated in case of prematurely fused sutures, the growth of bone becomes restricted in the plane perpendicular to the fused suture. So like if you focus over here, so if the sagittal is closed, so the brain cannot grow in the perpendicular to that. So in compensatory growth occurs in plane parallel to the fused suture, resulting in abnormal head shape. So if it is closed, if you can see the cursor closed, so it cannot grow in perpendicular to that. So what will it will increase in shape in anterior posterior diameter, just like over here. So it will become a boat shape. Now, coming to the craniosynostosis, the different types. So basically, we can divide it into two types. That is a primary craniosynostosis and secondary craniosynostosis. Then primary craniosynostosis can be further divided that whether a single suture is involved or a multi-suture is involved. So if the single suture is not, though, it could be sagittal, coronal, metopic, and lambdoid. These are the four types. If multi-suture is involved, then again it can be divided into non-syndromic and syndromic. In non-syndromic, the bicoronal is common. In syndromic, there are different syndromes which are Apert, Cruzan, Pfeiffer, etc., etc. Now, coming to the secondary craniosynostosis, there are certain conditions where it leads to the craniosynostosis. That's called metabolic hypothyroidism, rickets, bone dysplasias, fetal insult like this ischemia or hypoxic ischemic encephalopathy. There are some cases where because of increased DP shunting can lead to the although it's rare, it's not that common, but if a patient present to you, as we have seen that present to you with hydrocephalus at increased OFC, and then we do shunting and it's over drainage or some sort of leakage, then suddenly the pressure inside the brain decreases, and then it leads to the fusion of the sutures that can lead to craniosynostosis. So these are the different causes of craniosynostosis. So in primary craniosynostosis, the brain wants to grow, but there is no room for development. There is no room for increase size. And in secondary, there is no push. There is no a desire to grow. So that's why then it is called secondary, because it's not the brain, these sutures are closed, not because that it was primarily closed, but because there is no push or no force behind the bones to keep them apart. Now, coming to nomenclature, it's maybe a bit looking difficult and orchard, but just name, and in the next slides it will become clear. So for sagittal, that is scaphocephaly or boat-shaped. Then if the metopic is increased, it's called trigonocephaly, the triangular skull. If the coronal is involved, the plagiocephaly means that it is an oblique shape, or normally asymmetric skull. So if it's a unilateral coronal suture, then it will be anterior plagiocephaly, and if the lambdoid is involved, then it will be again plagiocephaly, but it's posterior plagiocephaly. And if bicoronal sutures are closed, then it's called brachycephaly or short skull. So brachy is short, scapho is boat shape. Just remember these two for the time being. So trigonocephaly, you can see that you just focus on this the brachycephaly, trigonocephaly, that how the shape changes. Anterior plagiocephaly, you can see. Posterior plagiocephaly, you can see. And scaphocephaly when it becomes a boat shaped. Now, coming to the sagittal craniosynostosis, that it's the most common type of 50 or 60%, 50 to 60% of the cases are sagittal and craniosynostosis. So scaphocephaly is called or dolichocephaly, that just like a boat shaped, anterior and posterior diameter is increased. So that's why it become a boat shape. So that's why it elongated. The male to female ratio is 4:1. Males are more commonly affected, and the frontal boning, occipital boning, palpable ridge over the sagittal suture can be seen. Isolated sagittal synostosis is rarely associated with deformity of the square and base of facial bone. Neurologic findings are usually normal. So you just see over here that this is the sagittal suture, it's closed, and because of this, as per Virchow law, we have studied that the growth will be parallel to the closed suture. So if it's parallel, so the length, the anterior and posterior diameter will increase. the growth will be in anterior and posterior direction, so that will become a board shape. You can see from in the picture that the skull is quite elongated and more board shaped. And these are the 3D images. Now, the next is the coronal synostosis, that it is a 20 to 30% of total cranial synostosis cases. Is the second most common type, and can be unicoronal, and coronal, with unicoronal being twice as much common as bicoronal, and it can be both. But unicoronal are more common, and if it is unicoronal, then it's called anterior plagiocephaly, and if bicoronal, then we call it brachycephaly, that is a short head, a short skull. You can see over here that this is closed and this is open. So because of this, it become the growth over here is stopped, so it remains small as compared to the other one. So it is compensated. In compensation, it is become elongated. So that's why the shape of the head is abnormal, and there is a flattening of the forehead on the affected side, that's called frontal plagiocephaly, and compensating overgrowth of the forehead on the opposite side, as I mentioned, and head deviates to the affected side. That sometimes it's called as cranial scoliosis as well. So if you look over here, so over here, this is the affected side, where it's least growth as compared to the other side, which is more in comparison to that, and that's why the different deviation and abnormality you can see, where the nose, the tip of the nose will point to the normal side, while the root of the nose will be dragged. You can see that if it's a normal side, so it will be dragged over here to the affected side. So from this, you can say that it's which type is involved. Also, if you see over here, the left eyebrow and orbit is a bit elevated as compared to the right one. Proptosis as an eyebrow on affected side with widened intrapalpebral fissure, giving harlequin eye appearance. So it's the name is mentioned almost everywhere in every book. So that's why I say that this is a comic character from Italians. I haven't seen myself, but that's whenever there is a discussion about craniosynostosis, so we always hear this harlequin. So it's a comic character. You can see that there is a hypotelarism. The distance between the two eyes is less as compared to a normal person, and there's a eyebrows are elevated. Now, coming to the metopic craniosynostosis, the other form is found account for 15% of the total craniosynostosis cases. The triangular head shape, it's very peculiar, where you can easily diagnose, and it can be seen by almost everyone. Can be feel very early. This triangular head shape, the trigonocephaly, that is you can see over here. The back of the head is broad, while front is narrow and pointed by a temporal nerving. There is again in the same. It also has the hypotelarism, that is the distance between the two eyes are less as compared to the normal one. And there is a prominent ridging, so you can feel, if you feel over here, so you can feel the ridge on the frontal side. Now, metopic craniosynostosis can be seen over here in this animation when the metopic sutures fuse too early. So you can see over here, this is the fuse that fused too early, and it's prominent. Now, lambdoid craniosynostosis is another form of craniosynostosis that's called as posterior plagiocephaly. So we have discussed previously that anterior plagiocephaly is because of the coronal suture, and posterior plagiocephaly, that is a abnormal or oblique head, it's because of the lambdoid suture. So it's also called as twisted head, because if you look from behind over here, so it seems that someone has twisted the head. So also that's why it's called twisted head appearance. downward and posterior displacement of the mastoid process on the affected side, and flattening of the apsilateral occiput on the flattening of the occipital skull on the apsilateral side, and posing of the contralateral frontal smooth. So in compensation, the frontal skull on the opposite side will be more prominent as compared to the other side. It's the rest of all the unilateral craniosynostosis, so it's not that common that we see. Now, a little bit of basic science that syndromic craniosynostosis. So far, we have discussed all the unilateral or single suture closures. So now coming to the syndromic craniosynostosis, occur with other anomalies as birth defects in manner which is clinically recognizable, and multiple sutures are involved. And the basic of this is that it is linked to the chromosome number 10 related to genetic mutation, particularly to the FGFR2 and in some cases FGFR1 mutation. Basically the fibroblast growth factor releasing genes. So it mostly upregulate the osteoblast and prevent the apoptosis. So it leads to the syndromic craniosynostosis. Deregulative epigenetic function leads to abnormal osteoblast function and lead to excessive bone fusion. Now, if there are 2-3 syndromes that are more common and more important, the one is the Cruzen syndrome. The one important point that you should remember is that hands and feet are normal in this syndrome. In all other syndromes, the hands and feet are involved, but in Cruzen syndrome, it is normal. The other features are that biclonal craniosynostosis presenting as a brachiocephalic short head, as you can see in the pictures, account for 4.8% of all cases of craniosynostosis, which is the highest of all syndromic. Among the syndromic craniosynostosis, it is the most common type. There is frontal bossing, thin lips, parrot beak. You can see the nose is just like a parrot beak, severe exophthalmos in almost every case, and mandibular prognathism is there. This is the point that one should remember. Now coming to the Alport syndrome, so it's Cruzen syndrome with symmetric syndactyly. This is the symmetric is important because in other syndromes we will see that in Pfeiffer that is asymmetric syndactyly along with the Cruzen syndrome. So syndactyly means that is you can see the fusion of the fingers. This is called syndactyly. So it's involved. The hands and feet are involved in this syndrome. There's acrocephaly, tall skull, brachydactyly. Brachydactyly means that the fingers and toes are short as compared to a normal person. And there's a dental abnormalities, cleft lip may be there. And then other one is the Pfeiffer syndrome, where multisutural craniosynostosis and asymmetric syndactyly. This is the difference between Pfeiffer and Alport. That in this syndrome we have the asymmetric syndactyly and brachydactyly. There is a conductive hair loss. The other is the claw leaf skull appearance. This is also a type of syndrome in which most of the sutures are involved. So it is the most severe form. Coming to the complications of the craniosynostosis, the facial abnormalities, the cosmetic issues for most of the parents that they come to see a neurosurgeon. There are psychosocial consequences because poor self-esteem and self-isolation because of the abnormal shape of the head. But the most important is the developmental delay. It is as high as 37% in untreated and single suture craniosynostosis. The more sutures involved, the more is the developmental delay and more severe form it is. The anomaly of speech and hearing may occur in this patient, and there is a respiratory problem in some people as sleep apnea. Syndromic patient may also have intrinsic respiratory abnormalities as well. It can also lead to intracranial hypertension, raised intracranial hypertension, because the brain wants to grow and there is no space, so it increases the intracranial hypertension. Now, although we haven't seen any such X-ray, which is a copper bitten appearance, that is the most sort of in most of the textbook it's mentioned. The ICP, whereas ICP occurs in approximately 14% of single suture and 47% of patients with multi-suture syndromic cystosis, and the other manifestations are crying because of the headache, due to raised ICP, vomiting, feeding difficulties, irritability. In extreme and late stages, untreated elevated ICP manifest as copper. That is shown here. Now I will rush to the last few slides. diagnosis is based on the history, physical examination, and imaging. So in history, we rule out, we ask about the risk factors, that is multiple pregnancy, uterine constants, maternal smoking history, maternal use of knife, turpentine, and phenytoin, warfarin ingestion, thyroid abnormalities, high altitude. So these are the various risk factors, although it's not that highly related. Like it's not mandatory that you see in every patient, but still you can look for it. Now, the most important is the physical examination. If you look for the head shape and asymmetry, so in the first glance, you will see that there is a abnormality in the shape and the symmetry. Then this skull and facial configuration. If you palpate over here, so there will be some sutural ridging. The ridge will be appear, and it's important to diagnose early, because in most cases the ridge appear first, and then the abnormality, the shape difference, different abnormality become visible. Then there is a fullness and patency of fontanelles, and then presence of ocular abnormalities. Then if it is syndromic, then it become obvious on the day one. But if not syndromic, so it take time to be appear. The cephalic end, because in most of the cases, the OFC may be normal occipital circumference, but the cephalic end is it is disturbed. So normally it's 0.76 to 0.83 in boys and 0.84 in girls. The imaging, that the most important that we always do to diagnose the case and confirm our diagnosis, so is the CT scan, 3D CT scan. Although in some books it mentioned that ultrasound and MRI have some sort of scale, but most common is, and most effective is, and most useful is CT scan 3D. Now, everything so far we have a normal head shape, but every abnormal shape is not craniosynostosis. So a little bit of positional plagiocephaly, also known as flat head syndrome or deformational plagiocephaly, because of excessive, mostly in one position, lying down in one position, the shape of the head, especially in neonates, big changes. It can be seen very frequently in some part of the world and in many areas. So it becomes if sometimes it's because of any disease, or sometimes because of the parents' unawareness, or some cultural issues. The head become parallelogram type and abnormal shape due to repeated pressures on one side, often confused with the posterior plagiography due to lambditis craniosynostosis. So how to differentiate between this is the predisposing conditions, torticollis, less tummy time, and sleeping position. And 46% of infants will have some degree of flattening on the skull by the time they are 4 months of age. In 1992 or 1994, there was a campaign in US where there was safe sleep syndrome, where SIDS were there, sudden infant death syndrome. To treat this, it was educated to lie the children should sleep, the neonate should sleep in a spine position, not in prone tummy position or prone position. So because of that, though the rate of the SIDS was decreased by 40%, sudden infant death syndrome was decreased by 40%, but there was a huge increase in number of craniosynostosis, and it was basically not was craniosynostosis, but it was positional plagiocephaly. Treatment includes counterpositioning, physical therapy, or molding. Now, there are some red flag signs that that can be alert you that whether it's a craniosynostosis or it's just a position. There's signs are if there is a raised ridge, so it's a definitive sign that the patient is developing craniosynostosis. It's already the suture is closed, and with time the shape will distort. Or there is slow or no improvement in head size over time as the baby grows following the OFC or the other parameters, and asymmetric orbit or facial features that you can look for it, and the posterior displacement of ear that in positional you can see over here that the ear is moved anteriorly, while in lambdoid plagiocephaly the ear is moved posteriorly. So this is the main point that you can differentiate between positional and lambdoid craniosynostosis. Also, the family history of normal head shape can aid to them. So there are some fun fact that in some part of the world, and even in Pakistan, in some areas where there is a trend that the occiput should be plain and it look beautiful. So they use these things so for the infants to sleep on them, and so that the posterior part of the head become flattened, and it's sort of the beauty sign in some part of the world, and it's in Pakistan, some areas, not in urban areas, but in rural areas of some part of the world. Now, coming to a treatment, although it's not related to a treatment, but it can be endoscopic strip craniotomies as well as the cranial reconstruction and open surgeries. The only difficulty is their blood loss, because the children are very sensitive to blood loss, and due to less blood volume, they can easily go to shock. There is a helmet molding therapy in its type of treatment, which babies fitted with special customized helmet and grab the shape of skull, although it's very difficult to keep them in this helmet. The duration of treatment can vary. And now I will share just a case that we have done this week. This is the patient that presented to us. It presented a bit late because the parents were reluctant to do surgery. But somehow this is the CT scan, 3D CT scan, and you can see that the left side of the coronal sutures are fused, and anterior plagiocephaly, that you can see that the orbit is slightly raised and distorted. This is another view of this. Let's see. Then we are scrubbing it. This is when we have removed the skin and the removed everything, and the bone, you can see it's visible over here that the raised ridge and fused coronal suture that we have seen, and this is a strip craniotomy that we have done. These are references, and I thank you. Any question?
Thank you, Dr. Sajad. Very detailed overview of cranial sutures and craniosynostosis. I would request any participant wants to add or wants to ask a question, they are welcome. Please.
I will have a question for you, Dr. Sajad. Usually, what are the indications of surgery in craniosynostosis?
Sir, the indication are that because of there are 2-3 main reasons. So if it is established that there is a craniosynostosis, so you have to operate within 6 months, because if you do not operate, there are 2 main reasons that we operate. One is the cosmetic reason, but more important is because if you do not operate, there will be developmental, there will be abnormal, there will be no space for the brain, and it will damage the brain function and normal development of the brain.
Dr. Sajad, I would just want to inquire, have you ever, you did not talk about expansile craniectomy, use stripped craniectomy, but have you ever used springs for expansion of craniectomy?
Sir, you're right, but so far when I searched the literature, there's no established established guidelines that it's better than the strip cranectomy. So that's why I skipped. The other thing is that it's more expensive and unaffordable for the most part of the world where we and the other colleagues are living. So that's why I skipped. Although it's mentioned and in some part of the world it's doing, but in literature there is no proven benefit of this expansile spring cranectomies with other than the strip cranectomies.
Any other participant wants to ask question? You're welcome.
I see here in the chat, Dr. Marwan Asadi have a question. Can you tell us how the high altitude of pregnant women make the fetus at increased risk of craniosynostosis?
So there is no in literature. I haven't found anything special that how it can affect or not. But these I mentioned earlier that these are mentioned that these are the risk factors, but there is no clear linkages that with every TUR it can happen, or there's established fact that it will happen. So they are the risk factors that are mentioned, reported by some, but that's not an established fact.
I have here another question in the chat from Dr. Asil Ibrahi. May I ask, Doctor, in case of multiple sutures involvement, can we do multiple staged procedure to correct the craniosynostosis?
Sir, in most of these multiple sutures, there is a syndromic craniosynostosis, and in syndromic craniosynostosis, the outcome is not good because we know that the brain is not that develop are not healthy. That so usually in the such cases, we do not go for unless there is a cosmetic reason that it's very obvious and rest of the things are normal. So then we go for. But so far we have done two sutures. The stage, if it is an interior and posterior, then we go for stage position. But if it's not, it's like if the sagittal and coronal, then we go in one go. Then we do it in one go.
Here is another question in the chat from Dr. Matasum Al-Asali. He has two questions. Question one, does seizure is complication of surgery or craniosynostosis itself?
Sir, it can be sort of a factor as well, because if there's a raised ICP, then it can lead to seizure as well. So in this complication, we haven't seen it that it's a complication because we do it, we do not open this dura. So it's extradural, you do the surgery extradurally, so you do not manipulate until unless there is some injury to the sinuses or something. So it may happen, but we haven't seen because the major complication or the drastic complication is that of that if you injure the sinuses, then it can happen. Otherwise, we haven't seen it.
I have another question. Can we depend on cranial orthosis alone without surgery, or it's not an option?
Sorry, sir,
A helmet. Can you depend on helmet alone without it?
You can use a helmet just to mold the shape. If there is a craniosynostosis and it's hampering the growth of the brain, then it's not an option. Usually, we use the helmet post-operatively. We like you have done the strip craniectomies, you have removed the part, but still the head is deformed. The shape is not in good shape. So then after surgery, for rehab purposes, you use the helmet so that you can get the normal shape that is acceptable to the parents.
Is it mandatory to give backed RBC prior to surgery in spite of HP level?
Is it, sorry, sir?
He's asking about blood transfusion. Is it mandatory to give blood transfusion?
If you use the bone wax in surgery, so usually we do not need the transfusion. But we always ask the patient and even the anesthesiologist to get the blood in hand, because the cushion with the in pediatric age is very less, and especially this they're 3 to 6 months of age. If you just lose because the average blood loss in craniosynostosis is 100 ml to 150 to 200 up to maximum 200 ml. So even that after 200 ml, if you lose further, then you have to transfuse some blood, because it's very difficult for the child to compensate for that. But usually it does not require, because whenever you remove the bone, you just with every place that is bleeding, because the bone bleed, you just place the bone wax, so it usually not be that much.
There is another question. In complete craniosynostosis with no signs of brain atrophy, craniotomy can be done in the first days of infancy?
So this is very hypothetical scenario. We haven't seen that there's a complete craniosynostosis in all. But usually we operate the standard time is between 3 to 6 months. If you operate too early, it's difficult for the child, for the parent, for everyone to get it. So the average time is 3 to 6 months that we usually
I think
do.
Other complications are too many, like complications of anesthesia, and even that would be not compensated earlier. So
Yes, thanks. I have here another question, but I think you already answered it about the best timing for and age for cranial surgery.
Yeah.
And as you mentioned, it's between 3 and 6 months,
Yes.
usually.
Even if it
Okay.
is delayed, you can do it, but this is the better. Like the previous case presented to us was at 1 year of age. So you have to do it, even if it's more than 6 months. But ideally, it should be done early.
Yeah, I have one question, that what is the end limit of surgery, which is the cutoff date where surgery would not be helpful?
Sir, you are more experienced in that, so I haven't seen any cutoff in literature, or maybe I haven't seen it. So if you can comment on that, I would be grateful.
Dr. Ahmed, what is your practice? But in majority of childs, we usually practice that if it is more than 3 years, their brain growth has already completed. So it is practice that surgery would not be very helpful after that if child comes. So, Ahmed, what's your stance on that?
Yes, usually for late surgery will be only for cosmetic regions, not
Yeah.
for
Not
developmental
for
delay or
benefit of
something. Yes, it will be only for cosmetic regions. And for this, there is no cut limit, I think.
So I
What
think
do you think, doctor?
it was a very good discussion on the second lecture, and again it was a very detailed presentation by Dr. Sajad. Very good effort and nice presentation. Sajad Ahmed, would you like to add something before we conclude?
No, it's a very nice presentation. Thanks you, Dr. Sohail Ahmed, and thank you, Dr. Sajad Allah, and thank you, Dr. Shahid Ayub. It's very nice session, very nice discussion, very nice presentations. And I think by this we can conclude our next. Dr. Shahid, do you have any final remarks? Closing
Yes.
words?
Again, I'm thankful to all the participants who are from all over the world. I cannot take their names individually. And then my utmost thanks to my two presenters, Dr. Sale and Dr. Sajad, for their um, brilliant effort and very good presentation. And after all, hats off to Ahmed, you, for being an Iron Man for this academic program. So this was our second session, very successful. Hope to see you everyone at our third session next Friday, which will be soon communicated. So thank you very much.
Sir,
Thank you,
one last thing
everyone.
I would like to add,
Okay.
sir, in Khyber Medical College, we have made the student interest group of neurosurgery and all other specialties. The students, medical students, are taking great interest in these interest groups. So, sir, my email is with you if you want to any sort of help in establishing any surgery interest group, neurosurgery interest group in your medical school. I'm always available.
Okay, we can have your contact number, WhatsApp number, and we can contact and we see what we can do. Thank you very much, doctors. And by this, we conclude our second session, and we can see you all next week, our third session, where we have 3 presentations. As joined from 2 programs, 2 different programs will be in the same day. Let's see the schedule here. Okay, that happened. Just wait a second. Next week we'll have okay, we have anatomy of the nasal cavity by Dr. Nawaz Khatak. Let's see. We have 2 presentations next week. First, anatomy of the nasal cavity by Dr. Nawaz Khatak, and the second will be anatomy of the nasal sinuses by Dr. Yusuf Turgot, and the moderator will be Dr. Salman Sharif. The time will be next Friday at the same time as today, 4 p.m. GMT and 7 p.m. Yemen time, 9 p.m. Pakistan time. So until then, thank you all for attendance and see you all next week. Thank you very much.
Thank you, everyone. Allah.